Hey, it's Dan Heckman here again, back and ready to talk about neoplasia, which is the second very important section of the pathology section. And once again, this is just going to be a breakdown and a foundation for the rest of the book, where you'll learn in more detail about neoplasia with each specific system. But in this section, we're just going to go over the basics, and there will be some unfortunate rote laundry list information sections, but I'll try to make it fun with some mnemonics and other ways to help you remember things. So pay attention, and once again, it's going to be very interactive, so get ready to answer some questions, and I think it'll be a lot of fun for you. So let's get started. So we're going to start off by talking about how cancers form. Cancer, of course, another word for neoplasia. Neoplastic progression. How does it start from healthy tissue and turn into cancer? How does that happen? So we'll start off by saying what the normal is. So let's say a normal epithelium. And we'll talk about skin because I'm going into the derm. So a little biased here. So let's say we have skin tissue. What comprises a normal epithelium? So we have on the ground floor, the lowest layer, there is what? What's that called? The basal layer with basal cells, all the stem cells that divide. And after these cells divide, they tend to mature, especially in the skin, and flatten out. As we see towards the top of the skin, there's the more apical, specialized cells towards the surface. They mature, the cells mature as they go towards the surface and eventually are shed, and the whole process starts over again. So what's underneath this? Well, we talked about it before. There's type 4 collagen in this layer. What is it? Type 4 on the floor is the basement membrane. Very good. And underneath the basement membrane, we have like arteries and nerves and other connective tissue. So that is a normal epithelium. And this is really important because we're going to talk about this a lot in the progression of cancer from healthy tissue to cancerous tissue. Good, so we know the normal. Now let's talk about the abnormal. But before we get into that, let's quick talk about how cancer cells, just very briefly, how they adapt to and resist medications. So there's a special protein called P-glycoprotein, where here's a not normal, but here's a cancerous cell, and sometimes when you give this cell chemotherapy to try to kill it, to complex with the DNA and stop proliferation and kill the cell, sometimes these cancer cells actually develop this channel that actually pumps out the medications. Wow, pretty neat, right? Let's see that again. Boom. And that is called MDR1. And it stands for multi-drug resistant protein 1. So that's important to know. Okay, now we talked about that brief little tidbit. Let's get into the gritty details of neoplastic progression. Alright, so now let's resume talking about the journey that normal cells go through when they're turning into cancer cells. Or another word is neoplastic cells. So speaking of neoplastic, the word plasia is going to be involved in each of the stages that these cells go through when they're turning from normal into neoplastic. So neoplastic, again, means neo means new, and plasia means growth. So new growth. That's another word for cancer. And a thing to keep in mind, actually, is when these cells are transforming into cancerous cells, they just become more and more lost in their identity. They forget who they really are. So you can think of them becoming more and more schizophrenic, essentially. So that's just a helpful little analogy to keep in mind. So let's do this. Let's talk about the different stages by playing a fun little game. So I'm going to visually describe what's going on, and you're going to tell me what type of plasia is taking place. Got it? Good. So let's talk about the reversible changes that take place first. So when cells increase in number, just increase in number, what's that called? hyperplasia, right? Hyper means increased growth, hyperplasia. That's an easy one. Good job. What about when, whoa, the cells are really starting to become lost? They're losing respect to their orientation, their size, their shape. What's that called? They're abnormally growing, becoming confused. I mean, the cells on top aren't supposed to look like the cells on bottom. They're supposed to be more differentiated, right? So these confused cells are called what? What type of growth is this? Dysplasia, abnormal growth. And another type of abnormal growth that's still reversible is, well, let's go through an example. So what's the lining of your main stem bronchus? It's columnar, pseudostratified, ciliated, right? Right. Okay. So when someone smokes, all this smoke irritant is going to really sort of tick off these cells, and they're going to say, hey, I don't want to be exposed to this smoke. I'm going to try to protect myself more. I'm going to change from this columnar type into a more protective type of cell that is, can you guess? Squamous stratified epithelium. So all these cells are more protective, and the smoke irritant can bounce off of these barricaded cells. So that's good in one sense that they changed and are more protective, but that's bad in another sense because guess what? They had to alter their DNA to change into these cells. And anytime you alter your DNA, you're running the risk of mutations and neoplastic progression. So that's actually bad overall. But what is this called? What is this metamorphosis called? This transformation from one adult cell type into another. That is called metaplasia. Very good. Now we're going to talk about some of the bad changes, the really bad ones, the irreversible changes. So, what happens when cells look like this? They are really lost. They look nothing like their primitive tissue. They have a very high nuclear to cytoplasmic ratio because all they care about is just dividing and making more and more copies of themselves. So what is that called? Anaplasia. Anaplasia. Ana means without, and plasia means growth. So that's without normal growth. It's essentially cancer on site. That's another name for it, is carcinoma in situ. And then if they keep progressing and have just continued uncontrollable proliferation and making clonal copies of themselves, that is full-blown neoplasia. We have reached the end of the line. They are cancer. Bad news bears. All right, so let's talk about some other changes that can take place. What about when fibrous tissue develops that's associated with these neoplastic cells? What's that called? Well, another word for fiber or fibrous is desmo. Think of like desmogliin and desmosomes as fibrous things attaching to each other. So that's called desmoplasia. And how does this actually develop? Well, the way that I think is there's probably a lot of inhibitory cytokines being released, right, to try to tell these cells to stop growing. What's one of the major inhibitory cytokines? TGF-beta, transforming growth factor beta. And in addition to inhibiting cells, what does this also do? This can stimulate fibroblasts to make what? Collagen. So that's my theory why there's this associated fibrous tissue, is because the fibroblasts are stimulated by this inhibitory growth factor. Anyway, that's just, I like to ask why and try to come up with explanations myself whenever I was studying. I definitely and highly encourage you to do the same thing. It helps material become more personal and stick to you better. You'll do much better on the tests and become a much better doctor as a result. So that's not too bad, is it? So, all right, good. So let's talk about some more. Sometimes these cancerous cells start to evolve enzymes that can tear up tissue and tear up the basement membrane in endothelial cells. By the way, what type of collagen is in the basement membrane? Type 4. So they must have type 4 collagenases that can tear through, and then this creates a passageway now for these neoplastic cells to sort of army crawl their way through and spread. What happens when they spread? What's that called? Metastasis. Very good, but not very good for whoever this is taking place in, because that means the cells are going to end up in other tissues and worsen the prognosis. And when these cells reach other tissues, they're going to need to make new vasculature. What's that called? Or what's a cytokine that is involved in that? They're going to need to release VEGF, FGF that we talked about before to stimulate neovascularization and give themselves new blood supply wherever they end up. So those are the main types of plasias and the main progression from normal epithelium to cancer. Pretty cool, right? And you figured it out all on your own. You got all of them right, I hope. Let's now talk about grade versus stage. So essentially grade is just what does the tumor look like? What is its appearance? And you can think of this on a scale of 1 to 4. So here's the normal tissue. How closely does the cancerous cell resemble the normal tissue? If it resembles it almost identically, is that a high or a low grade? That's a low grade. That would be like 1. Remember, the scale is from 1 to 4. So what if the neoplastic tissue is very dysplastic and does not resemble the normal tissue very much at all? Like we saw here with these anaplastic cells. Very high nuclear to cytoplasmic ratio and very abnormal and primitive appearing. Is this a high or a low grade? It would be a high grade, probably grade 4. Good. So that's essentially what grade is. How differentiated is the cancer? Is it well differentiated, or where it appears like the normal tissue, or is it not differentiated and primitive looking, high nuclear to cytoplasmic ratio like we see here, and has a very high grade? Let's next talk about stage, and stage is very important because this determines the prognosis. So that's why patients care about stage, and that's why you should care about stage too, more so than grade. Grade is for pathologists. Stage is for patients in medical treatment. So we use the TNM staging system to stage cancers. And essentially, each of these letters stands for something different. And the more letters that are involved, the higher the stage and the worse the prognosis. So T essentially stands for tumor. How big is the tumor? And it's just embedded in tissue. So how big is the tumor in the tissue? That is the T, the extent of the T. If it's a big tumor, it's going to be a higher number for T. All right. N is for nodes, lymph nodes. So how many lymph nodes has this cancer spread to? Okay. And the more nodes, the higher the number for N, the worse the prognosis. And M is for, you guessed it, metastasis outside of lymph nodes, and this is always stage 4. Again, this is from 1 to 4, and if M is present at all, if there's any metastasis outside of lymph nodes, that is stage 4. Metastatic cancer, the worst prognosis. So here we see it going to the brain. Flash quiz. Ooh. So, very easy question. What are the 2 main types of neoplasia? Benign and malignant. Now it's time to talk about tumor nomenclature. How do we name tumors? So, like we just said before, there's benign and malignant types of cancers, and that determines how we name them. So benign cancers, what do they end in? What is the suffix that they end in? And malignant, what do they end in? So benign end in oma, and generally just oma, nothing before that oma, like we'll see with malignant. Malignant, in general, depends on if it's derived from epithelial tissue or mesenchymal tissue. If it's from epithelial tissue, what do they end in? What's the suffix? Carcinoma. Very good. What about mesenchymal tissue? Sarcoma. So that is a very general rule, and most of the time it holds true. So keep that in mind, and you'll be able to name almost any cancer and figure out where it's derived from. So let's get some practice. So let's start with some epithelial types of tissues, and we're going to go through. There's a benign counterpart to epithelial tissue, and there is a malignant counterpart. So here is a polyp in a colon. What is this called? It's called a tubular adenoma. It sort of resembles a strawberry on a stick, and they are benign, but they're also pre-neoplastic, so you got to get rid of them. That's why we have colonoscopies at what age? What age do they start? Age 50. Very good. All right, what is the malignant counterpart to these tubular adenomas? Here's what it looks like. This is full-blown adenocarcinoma. So the carcinoma implies from epithelial malignant tissue. Very good. And you can see here that it's necrotic, fungating, and in general very ugly, as opposed to the benign tissue, which is circular, circumscribed, and well confined to one area. So that's how you can differentiate, in general, benign and malignant tumors. And also a very general rule is remember the M for malignant. Remember that M stands for metastasis. Anything that metastasizes is malignant, for all intents and purposes. All right, how about blood vessels? What is the benign counterpart to blood vessels from endothelial cells? Here's a common USMLE question. It'll ask about a kid who has these lesions, and then it will ask what's the next best step in management. First of all, what are they? Capillary hemangiomas. And what's the treatment? Nothing. You just watch them, and they will spontaneously regress over months without any scarring. They'll completely go away, completely fade away. Well, what is the malignant counterpart to capillary hemangiomas? Angiosarcoma, such as we see in the liver when someone's exposed to what types of agents? Vinyl chloride, arsenic, thorotrast, VAT. We'll talk about that a little bit later. So that's angiosarcoma from epithelial malignant tissue. All right, what about smooth muscle? What's a benign counterpart to this? Give you a hint, it's very common in the uterus of almost more than half of women, and it's a common cause of irregular bleeding. These are called, the common term is fibroids, but the correct term is uterine leiomyomas. Okay? What's the malignant counterpart to this? Well, we said leiomyoma. Let's just add a leiomyosarcoma. So add the sarc to it, and we have malignant. Finally, let's talk about bone. What's a benign outgrowth? A little nubbin off of a bone. This is just called an osteoma. Osteoma from bone, benign growth. Just chip it off. Easy removal. What's the malignant counterpart to this? You'll see it in a kid who has knee pain, maybe an adolescent who's in football practice, fractures his lower part of his femur after just a small hit. What's this? You see a sunburst appearance on X-ray. Codman's triangle. This is osteogenic sarcoma. Very good. What's the mechanism, or what's the gene associated with this? The RB, retinoblastoma tumor suppressor gene. So again, we have benign and malignant types of cancers. But what are the fundamental differences between these two types of tissues? Let's start with benign first. What are the characteristics of benign tumors? Well, they're slow growing, okay? They're round and symmetrical. They're often surrounded by a fibrous capsule. And remember what I was saying about desmoplasia and how whenever a type of cell is growing too much, that the surrounding cells are going to try to inhibit it with what cytokine? TGF-beta. Well, once again, this TGF-beta might stimulate some fibroblasts around here, and they might synthesize collagen that leads to this fibrous tissue that's associated with cancers. Okay, so those are benign. They're just sort of nice, neat looking, as opposed to malignant, which are not. They're irregularly shaped, necrotic, ugly, fungating masses, often with bleeding and hemorrhaging and other nasty stuff. And the most important thing, like I said before, what is it? The M of malignant stands for metastasis. They can spread. They're dangerous and deadly. As we see it metastasizing here. Ooh, scary.